really encouraging them to take steps to stop any didactics that morning on Thursday, April 3rd, and to encourage heavily faculty attendance. So we have a 2 months head start on that. And I will be emphasizing that every grand rounds as we come. So with that, I'm going to introduce Dr. Carlos Palacio and welcome everybody to our Thursday Internal Medicine, Department of Internal Medicine grand rounds, named after our founder, Roy Benke, who I showed a couple weeks ago at my grand rounds talk. So we have definitely another speaker of excellence in our series here today. Dr. Carlos Palacio is a graduate of the Albert Einstein College of Medicine family of residencies. So he graduated internal medicine from one of their training sites. And he then, after a short stint with Tufts University, actually joined our faculty in the Moffitt Cancer Center as an academic hospitalist. Carlos spent about 4 years at Moffitt before he found his love of endocrinology and applied and successfully entered our fellowship run by Dr. Joaquin Gomez Daspet. And he entered in 2014 and was a star fellow during his 2 years here with multiple abstracts and presentations he made during that time. He went off to private practice for a few years, but we were able to lure him right back to USF Internal Medicine for the third time, if you remember his first time with Moffitt, second time as a fellow, now back as an attending. Since 2020, September of 2020, Carlos has been with us here in the Division of Endocrinology. He does an outstanding job with our fellows. He is the director of our Thyroid Nodule program. And so today we are blessed with Carlos giving a presentation on the evaluation and management of thyroid nodules. Without further ado, one of the most happiest, always smiling people. I just love being around him. He lights up a room. Dr. Carlos Palacio, please take it away.
Thank you, Dr. Lezama, for the very kind introduction. So let me start sharing my screen here. Let's see. Can you see my screen?
Here,
do display
presenter.
Settings. Yeah, go to display settings. I just learned this 2 weeks ago. One of those top ones should be the one in the middle, I think is in the top.
The display settings.
I think it's the one next to it. So I'll walk over there, help you. I'll be right there.
Yeah, right in there.
We got it.
There you go. Perfect.
Thank you very much. We appreciate it.
Sure.
Thank you. Okay, so again, Dr. Lezama, thank you for a very kind introduction today. The main educational aims with this lecture is providing to the non-endocrinologists a very practical understanding of the up-to-date management and evaluation of thyroid nodules. We'll spend some time talking about the physical examination, ultrasound diagnosis, and the current available criteria and systems for thyroid nodule cancer risk stratification. And one of my main objectives with this presentation is sharing the important concept that the management of thyroid nodule is multidisciplinary and have to involve collaboration between radiologists, surgeons, primary care, and endocrinologists. So what is the thyroid nodule etiology? We have basically 4 main categories: hyperplasia, chronic inflammation usually associated to autoimmune disorders, thyroid malignancy, or metastatic disease, being the most common mechanism for the thyroid nodule development, the hyperplasia. In that category, we have the follicular adenoma, the colocyst, the adenomatous goiter, all benign conditions. In terms of chronic inflammation, the typical thyroiditis being the most common Hashimoto thyroiditis or lymphocytic thyroiditis. For thyroid malignancy, that by the way, represents only the 5% of all nodules diagnosed. 95% of the nodules will be associated with the two initial categories discussed and benign, and only 5 to 7% will be related with thyroid malignancy. And that thyroid malignancy, follicular, papillary, being the most common. And metastatic disease is possible to the thyroid, causing thyroid nodules, from renal cell carcinoma, from melanoma, for the small cell lung cancer, to mention some of the most common sources of possible metabolic metastatic disease to the thyroid. So how is the process of the thyroid hyperplasia? So multiple studies have defined some stimuli. It could be iodine deficiency, could be exposure to ionizing radiation. And this stimuli will lead to the production of oxidative free radicals and increased cellular proliferation. The nodule could have that proliferation organized and slow over time. That's what we see in a benign goiter. That growth could be very rapid, related to hyperfunctioning if the patient has already a TSH receptor mutation, or could be a dedifferentiation leading to thyroid cancer if the patient has a KRAS or BRAF mutation for the predisposition. But the mechanism is the same. It starts with a stimuli and will be an initial phase of those oxidative free radicals that will increase the cellular proliferation, going in hyperplasia or going to dedifferentiation. So what is the epidemiology? Before the thyroid ultrasound, as shown in these studies in the right hand of your screen, the prevalence by palpation was pretty low, 7, 10%. What has really increased the number of thyroid nodules and the prevalence of thyroid nodules is the widespread use of the thyroid ultrasound. Now we have a prevalence which is 50 and 70%. The prevalence is higher in areas with low iodine intake for the influence on the mechanism of the thyroid nodule development. And as I explained, also the exposure to ionizing radiation is an important factor for the development of thyroid nodules, benign and malignant. Thyroid incidentalomas. They are extremely common. You can see it in almost 65% of ultrasounds, including carotid ultrasounds, general neck ultrasounds, 50% on CTs and MRIs, and 1 to 2% in PET scans. The large numbers of thyroid incidentalomas are also driving a higher annual incidence of those thyroid nodules. Now, 0.1% per year, with 10% lifetime probability that any of us is going to be diagnosed with a thyroid nodule. The thyroid nodules are 4 times more common in women, and studies done during pregnancy have identified hormonal influences, both from estrogen and progesterone, as main factors leading this thyroid nodule development being more frequent in women than men. So what is the rate of malignancy in thyroid nodules? So multiple studies have shown that goes from 5 to 7%. So the big majority of your thyroid nodules are going to be benign. Now, in terms of the PET-CT and the FDG-ABET or hypermetabolic thyroid nodules, although those incidentalomas are only 1 to 2%, are very significant because they could have as high rate of malignancy as 27%. And any of those thyroid nodules will require further evaluation with FNA if they are more than 1 centimeter in size. The important point here to understand is that the big majority of the thyroid nodules are going to be benign, almost 95% from them. And from that 5% that is malignant, the 80% are going to be papillary thyroid cancer. We have excellent survival and seems to have, in general, a slow course of development and disease progression. What I wanted to show from this data from the SEER report from 2022 is how the number of estimated new cases per year for thyroid cancer has increased along with the increase of the incidentalomas or thyroid incidentalomas and the widespread use of thyroid ultrasound. So we have that light green line on the top of the graphic going progressively up. However, there's no change on mortality. We have a flat line on thyroid cancer mortality from 1992 to 2022 in this data, showing that the early detection and the overdiagnosis of thyroid nodules has not impact in the overall mortality rate. Something to do a reflection on in our use of thyroid ultrasound and the appropriate cost-effective indication for this important radiologic tool. Now notice that the 5-year relative survival remains 98%. So let's start talking about the clinical evaluation of a patient showing to your office with a thyroid nodule. In clinical history, first thing to identify is any compression symptoms. You want to ask the patient if there's any sensation of a lump, foreign body on the throat, if there's any dysphagia, shocking sensation, odynophagia, if it's positional dyspnea, hoarseness, or even pain. Pain is less frequent, but could be associated to thyroid cysts with acute hemorrhagic transformation. So any of these symptoms would lead to additional evaluation and testing, including considering a CT of the neck or ENT evaluation for a possible thyroidectomy. On the other hand, in terms of the history, it's also important to determine the risk factors for thyroid cancer. Exposure to ionizing radiation or beam radiation, family history of thyroid cancer. Very important if it's any relative with medullary thyroid cancer to think in multiple endocrine neoplasia 2, type 2A or 2B, leading to the request of a red oncogene mutation, or syndromes that are related to thyroid cancer. The current disease, which is that disease with multiple hermatomas, the familial adenomatous polyposis is also associated with higher incidence of papillary thyroid cancer. The Carney complex, where patients present with multiple benign tumors, including cardiac myxomas and different areas of body hyperpigmentation. So those familiar syndromes are important to be identified because increase the chances for papillary thyroid cancer. Also, if there's any possible concern for medullary thyroid cancer, is an important clinical factor to be identified in the evaluation of thyroid nodules. In order to perform an effective thyroid examination, it's important to have a clear understanding of the anatomy. First of all, the central neck will be ubicated between the hyoid bone and the upper level of the clavicles. And the thyroid gland is just below the thyroid cartilage and just at the level of the cricoid cartilage. So that's important to keep that in mind when you're doing your examination. And an important anatomical variant is the pyramidal lobe. Could happen up to 20% of the general population. Is a remnant of the thyroglossal duct. And the pyramidal lobe is frequently mistaken for a thyroid nodule. So it's important to keep that in mind when we're doing that assessment. and different visualization will be required with different views with the ultrasound to confirm it's a pyramidal lobe. Usually it's a structure that seems to be on top of the middle of the thyroid, on top of the isthmus, and a very common anatomical variant. In the anterior neck is multiple structures in relation to the thyroid. We have the internal jugular veins more laterally in direct contact with the thyroid, the common carotid arteries. This graphic is just to point out the area where the recurrent laryngeal nerves are. They are run in the size of the trachea. And when we are planning or discussing with patients about any kind of thyroid surgery or FNA thyroid biopsies, this relation with the recurrent laryngeal nerves is important to keep in mind. Not showing this picture, but always important to remember that in the back of the thyroid, in the back of the right thyroid lobe, in the lower inferior lobes are located the parathyroid glands that releases the PTH, important hormone for the balance of calcium and vitamin D in your body, and they're usually smaller than 1 centimeter in size. So for the thyroid physical examination, first step is making the patient know that during the exam could be a shocking sensation. And that is important. During the years, I have noticed that don't give the patient that particular warning always lead to a very unpleasant exam. In terms of this patient, you wanted to have the neck completely exposed and asking the patient to drink a sip of water. Once the patient is drinking a sip of water, it will be easier to notice irregularities on that thyroid gland or be able to appreciate a lump or thyroid nodule that will move once patient is drinking water. So that tool will have some water and little cups available in your office. Comes very handy for the exam of the thyroid gland. The classic palpation, you're going to be standing in the back of the patient and putting your fingers on both sides and asking again the patient to swallow will allow you to identify in a very easier way a thyroid nodule. Usually a thyroid nodule that's bigger than 1 centimeter will be palpable, especially it is more in the anterior location. And also in this graphic is shown the two fingers technique that is done being standing in the front of the patient that could be also used for further information from that thyroid exam. When a patient is presented to your office with a thyroid goiter, it is recommended to perform the Pemberton sign. This test is done asking the patient to raising the arms all the way above the shoulders, then putting the hands on the sides of the head. And what it's trying to do is creating a movement of the goiter. So it's two things happening when a patient with a goiter moves the arms up. Number one, the goiter goes down to the thoracic outlet and could be compressing the superior vena cava, or in goes the movement of the clavicles is going to press both internal jugular veins on the sides. So the result of this is or cyanosis. The patient will have a facial cyanosis, we have or plethora, or will develop a significant congestion and redness as we see in this picture. If a Pemberton sign is positive, it's a clear indication for a total thyroidectomy. So doing this test has a significant clinical relevance in your evaluation for patients with a thyroid goiter. So what laboratory testing I need to do a complement in the evaluation of a thyroid nodule? So we need a TSH with the main goal to exclude toxic thyroid adenoma or a multinodular thyroid goiter that could be toxic. What is the TSH that's really meaningful? What is the TSH that will trigger further testing? It's a truly suppressed TSH, less than 0.1. And we wanted to obtain levels of free T4 and free T3. If those are normal with a suppressed TSH, it's a condition that we call subclinical hyperthyroidism. If the TSH is suppressed with elevated free T4 and free T3, that will be hyperthyroidism. In any of those two circumstances, before considering a FNA biopsy, we need to obtain a thyroid obtainment scan that will show what nodules could be hyperfunctioning and therefore having a less risk for cancer, and what nodules are not functional or photopenic that we call cold nodules. Those nodules will have a higher risk for malignancy and will require an FNA. On the other hand, if the TSH is elevated, determine the possibility of the presence of Hashimoto thyroiditis as indicated with TPO antibodies, as Hashimoto thyroiditis is the most common thyroid autoimmune disease. So we definitely need to get a TSH, and that TSH will lead to further testing in the thyroid nodule evaluation. The tests that we don't need, and they are not recommended for the routine evaluation for thyroid nodules, are the thyroglobulin and the calcitonin. The thyroglobulin is produced only by follicular cells. So for patients that had total thyroidectomy, could be a tumor marker because we will expect the thyroglobulin levels to be undetectable after a total thyroidectomy. But if a patient has an intact thyroid, the thyroglobulin will be detectable and could be elevated by inflammation, could be elevated by thyroiditis. So in a patient with an intact thyroid, the specificity for rates of malignancy of the thyroglobulin is not is not having or is not correlating to a significant clinical value, so it's not recommended. Calcitonin. If a patient has history, family history of medullary thyroid cancer or family history of thyroid cancer, and it's coming to your evaluation with a highly suspicious nodule, calcitonin could have a value for a screening of medullary thyroid cancer. But in the general population, has been done multiple studies showing that it has a poor specificity and it is not cost effective. The poor specificity is because systemic inflammation related to systemic uh, autoimmune conditions could cause some elevation on the calcitonin, same patients with acute infections, and will lead to indeterminate values. They are in that range between 10 and 50 and can lead to unnecessary FNA biopsies and further testing. A calcitonin level will be concerning for medullary thyroid cancer when it's more than 100. And that has a sensitivity more than 60% and a specificity of 100%. So in summary, the role of calcitonin testing for thyroid nodules should be reserved for patients with family history of thyroid cancer in a highly suspicious nodules. So we got our patient with a suppressed TSH, patient underwent a thyroid uptake and scan, and now in this image in the right side of your screen, you can see a typical hot nodule or hyperfunctional nodule. Taking all that uptake, looking black, and the other side of the thyroid is not getting any uptake, it looks suppressed by the hyperfunctioning of that toxic thyroid adenoma. Hot nodules have a very low rate of malignancy, less than 3.1%. So it's not recommended an FNA for those nodules. If your patient is hyperthyroid and you perform an FNA, it's a possibility of triggering thyrotoxicosis. That's another concern with this kind of a scenario for your hyperthyroid patient with a toxic thyroadenoma. But in general, it's important to be aware that this kind of hyperfunctioning nodules have a very low rate of malignancy, less than 3.1%. On the other hand, if you know if your nodule is photopenic, it's a cold nodule. Um, those nodules we have a risk of malignancy that goes as high as 25%, and the FNA will be indicated. So what is the indication of thyroid uptake and scan in the evaluation of thyroid nodules will be basically two. Number one, the presence of a suppressed TSH with the concerns of subclinical hyperthyroidism or hyperthyroidism. And number two, a patient with a multinodular goiter and multiple of those nodules meeting criteria for FNA thyroid biopsy. So the uptake is going to guide you which ones are photopenic, which ones are cold in the uptake, have a higher risk, and will benefit the most from the FNA thyroid biopsy. Key element for the evaluation of the thyroid gland and thyroid nodules is the thyroid ultrasound examination. So what is the questions that we need to answer with the thyroid ultrasound examination? Number one is a thyroid goiter. So we need to determine the size. It's a heterogeneous gland that could suggest thyroiditis. And this is very relevant because patients with lymphocytic thyroiditis or Hashimoto thyroiditis will have pseudonodules. The pseudonodules are changes on the gland caused by the chronic inflammation that looks like lumps, but it's not a lump. It's just changes on the tissue. And those will now need a biopsy. So it's important to keep out of mind trying to avoid unnecessary FNA biopsies. Is the gland hypervascular? Again, that will go with the presence of thyroiditis, right? Graves' disease. You will see on color Doppler a significant increase of the blue and red images on both sides that we call thyroid inferno. It's a multinodular gland that we need to maybe consider for the thyroid uptake and scan because it has 8 nodules and multiple of them are meeting criteria for FNA. Are posterior nodules for we concern for parathyroid adenomas. Remember, the parathyroid glands are located posterior to the mid and inferior thyroid lobes. So the presence of dark or hypoechoic nodules on the back of the thyroid posterior to the thyroid will raise that concern. Is any lymphadenopathy? And in terms of the nodules, we need to get information from size, composition, echogenicity, shape, echogenifocyte. Echogenifocyte basically means areas where the sound wave has a higher reflection. Calcification will be a cause for that. So it's basically referring to identify calcification around or inside of the thyroid nodule. So those elements are important to include in your thyroid ultrasound examination. And when we do a thyroid ultrasound, we basically see in this cross section, image of the thyroid, right? It's important to identify the strap muscles in the front of the neck, the sternocleidomastoid muscle laterally, which is this large muscle that you can see in both sides, and then all the strap muscles in the middle. They include the sternohyoid muscle and the omohyoid muscle. So you will be able to see all these structures in your thyroid ultrasound. Here are all those important anatomical landmarks in the ultrasound image. In the front, the platysma, and looking then the strap muscles, we have the sternohyoid muscle more anterior, more lateral, the sternothyroid muscle. In very lateral, the largest muscles is the sternocleidomastoid muscle, then seeing the relation with the common carotid artery in direct contact with the thyroid, more lateral at the internal jugular vein, and posterior to the thyroid lobes, the esophagus, and also the paraspinal muscles. So in terms of the thyroid gland measurements, the normal thyroid gland will have a length between 4 to 6 centimeters and the AP diameter run from 1.3 to 2.5. So keep in mind these measurements before we designate or we call a thyroid gland a goiter. There is the tendency to overcall thyroid gland with nodules a goiter, and really that designation means that the size are above this normal limits. The thyroid gland echogenicity is referring again to the reflection of that sound wave back to the probe, and the normal is the image on the top. Seems to be very similar to the salivary glands. So a healthy normal thyroid gland will look very light gray in the ultrasound, and the related with thyroiditis in the lower image will be more darker. So the lower image in the right side of your screen is the image that you will expect for a patient with Hashimoto's thyroiditis. So in terms of the thyroid nodules, what will look to be worried for the possibility of thyroid cancer? So I like this abbreviation and simplification from the American Association of Clinical Endocrinologists that pointing out the main factors that increases the risk for thyroid cancer in our ultrasound evaluation. Suspicious ultrasound features, the presence of abnormal lymph nodes or extracapsular invasion, those will increase the risk for malignancy. On the other hand, if it's a purely cystic nodule, we have higher chances to be benign. Spongiform nodules, that are those nodules that are mainly cystic in component. Also, we have a lower risk for malignancy. So we go from a benign nodule, which is completely cystic, to a nodule that is a higher risk for malignancy, solid, darker or hypoechoic with suspicious ultrasound features. It may be related to abnormal lymph nodes. So let's review briefly what we look in the thyroid nodule composition, right? The first image, image A, is a classic solid thyroid nodule. And this nodule is what we call hypoechoic, it's darker. That nodule A is a nodule with a less intermediate risk for thyroid malignancy. And I wanted to compare with the image in the lateral side and the right side of your screen. That's the typical spongiform nodule that has multiple microcystic areas, and that is a benign nodule. Image D is a pure cystic nodule. It's also considered benign. So in the composition, we already have some information of what is the risk of malignancy from that nodule. In terms of the thyroid nodule echogenicity, what is called hyperechoic is the nodule in the upper left quadrant of this slide. Then you can see isoechoic, basically meaning looks like the surrounding gland. Hypoechoic, darker than the surrounding gland. And very hypoechoic is a finding highly concerning for thyroid malignancy. One of those ultrasound findings related to a high risk of thyroid malignancy. The normal thyroid nodule shape is wider than tall, which is a concerning feature is being taller than wide. Taller than wide seems to be over called or overdiagnosed in the ultrasound reports. So it's important here to clearly determine if the ratio, the anterior posterior size divided by the transverse ratio is more than 2 millimeters, that's a truly taller than wide nodule. And as we're going to discuss in multiple studies, this has a more than 90% sensitivity for thyroid cancer, the finding of a taller than wide nodule. And a truly taller than wide nodule will be seen in different views, not just on the transverse view, you're also going to be in the longitudinal view. we need to look for calcifications or echogenic foci, right? That's what we see here on the left side images. On the top, a typical big calcification or coarse calcification that will create acoustic shadowing. And on the lower image of the right side of the screen, multiple punctuate calcifications that will be a concern for micro calcifications, highly concerning for thyroid cancer. Then here on the left side of the screen, you see on the top lobulated irregular margins, also a very concerning feature, a feature for thyroid cancer, for thyroid malignancy, and possible extrathyroidal extension as seen on the lower image there on the left side. Both are highly suspicious features for thyroid cancer. So this is an interesting study where more than 20 different reviews for sonographic characteristics on thyroid nodules were compared to come with a sensitivity and a specificity for each one of those findings. So for hypoechoic nodule, you have a sensitivity for thyroid malignancy of 81%. And for marked hypoechoic, the specificity is 94%. Microcalcifications, 89% specificity. A big calcification will be 94%. The presence of lobulated with regular margins, 80%. Being taller than Y, 92% specificity for thyroid malignancy. So in the reports, always look for these findings in that are findings that are highly suspicious for thyroid cancer, being taller than Y, irregular lobulated margins, marked hypoechogenicity or a very dark black nodule, in presence of lobulated margins, microcalcifications. This is an interesting study where 100 patients went to surgery, then they went back and looked on the ultrasound characteristics, and they found a correlation with those highly suspicious features and the more aggressive type of cancers. So in the left side, you have the table of the follicular variant of papillary thyroid cancer that usually has a better prognosis than the classic papillary thyroid cancer. So in the classic papillary thyroid cancer, 95% of the nodules were solid, as you can see, and 61% were hypoechoic. And the 61% has lobulated margins, and 40% has microcalcifications. So this study kind of proven after surgery a clear correlation between those suspicious findings and the frequency in thyroid cancer. In 2015, the American Thyroid Association proposed this ultrasound thyroid nodule risk stratification. And let me start from the bottom where they define benign a thyroid cyst, not recommended FNA. Then they consider a group called the very low suspicion, basically nodules, they are mainly cystic with spongiform, and those it was recommended just observation. Then determine the low suspicions or mildly suspicious nodules that will have some significant solid component, and there was recommended biopsies when they were bigger than 2 centimeters. And for the intermediate suspicious, the solid hypoechoic nodules, the recommended biopsies was larger than 1 centimeter. And for the highly suspicious also biopsy, it was larger than 1 centimeter. And that high suspicious was given a rate of malignancy more than 70 to 90% and will be a nodule with microcalcification. That's the first image in your top left corner, or will be a nodule with lobulated margins, nodule with extrathyroidal extension, or along with an abnormal lymphadenopathy. The problem with the 2015 risk stratification is that was leading to a large number of unnecessary FNA thyroid biopsies. So we're going to discuss that more in details with some recent studies. The other very common thyroid nodule ultrasound risk stratification comes from the American College of Radiology. It's called ThyRAS, the Thyroid Imaging Register and Assessment System. This system uses a scoring system and look on the composition, echogenicity, shape, margin, presence of calcifications, and give a score. And a score of 4 or 6 will be a moderate suspicion, and a score more than 7 will be a highly suspicion. In this system, the FNA thyroid biopsy of 1 centimeter nodules is only indicated for the highly suspicious nodules. We get more details on this. This is the rate of malignancy associated with those stratification system and the sonography pattern. So let me start with the 2015. They give it 70 to 90% rate of malignancy for the high suspicious, for the intermediate 10 to 20, low suspicious 5 to 10, a very low suspicious 3%, benign 1%. This was determined with studies where was correlation between the ultrasound findings and the histopathology after surgery. The reason why the rate of malignancy was lower from 2017 going forward is because in 2017, some of those non-invasive tumors called the non-invasive follicular tumors with papillary-like features were excluded as thyroid cancer. So that reduced the rate of malignancy in those findings. So the 2017 American College of Radiology ThyRAS show a high suspicion nodule of ThyRAS 5 to have a chances to be malignant 20 to 50%. And that actually was confirmed with recent studies in 2024 by the American Thyroid Association that published an update on that rate of malignancy. So a high suspicious nodule will give you a 20 to 50% chances of malignancy, requires biopsy. If it's larger than 1 centimeter, the ThyRAS 4, 5 to 20, ThyRAS 3, 5%, ThyRAS 2, less than 2%. So it's a common ground that a very low suspicious and benign nodules should not have a biopsy because of the low chances for malignancy. So what system performs better? The 2015 American Thyroid Association Thyroid Nodule Stratification of the American College of Radiology ThyRAS. So this is an interesting study that took 120 patients that went surgery, then went back, and they compared those ultrasound characteristics. So what they determined is that the sensitivity, specificity, positive predictive value, negative predictive value are pretty much the same. So in terms of the diagnostic performance in being a rule in, rule out testing, they are equivalent. The main difference was for which one is more cost effective. And in this study that took multiple prior studies, a meta-analysis done in the ThyRAS and done also for the American Thyroid Association system for the 2015, they found that the number of unnecessary thyroid biopsies was 25% only using the ACR ThyRAS and was 50% of unnecessary biopsies done using the 2015 American Thyroid Association stratification system. So pretty much is the double of unnecessary FNA biopsies when that system is implemented by itself. So although they are performing the same in terms of positive, negative predictive values, the 2015 ATA stratification system leads to more frequently to unnecessary FNA biopsies. And that's what is indicated here with the blue ball arrows. Now, the American Thyroid Association is working in the new guidelines. They are going to be published before the end of the year, the 2025 guidelines. So will be interesting to see new studies and see how that perform in this item of unnecessary thyroid biopsies. So to summarize, the 2017 TIRAS compared with the incoming 2025 ATA guidelines will establish a kind of a new thresholds for FNA biopsy and follow-up intervals. So for the 2017, which is the one that we are currently using, for nodules that are benign or they are mildly suspicious, TR1, TR2, no surveillance, no biopsies needed. For nodules they are mildly suspicious, basically a solid nodule isocoic, will be indicated biopsies more than 1.5 centimeters. And the American College of Radiology recommend a surveillance for 5 years. This comes from the original studies done for the TIRAS, showing that was very infrequent significant changes on thyroid nodules beyond 5 years. So they recommended to follow any mildly suspicious nodule TAR4, any moderately suspicious nodule TAR4, TAR3 mildly suspicious, TAR4 moderately suspicious, or any highly suspicious nodule TR5 for at least 5 years in different intervals. It could be, a year 1, year 3, and then 5 years, or yearly for the 5 years. So that comes from that data. On the other hand, what the 2025 ATA new guidelines wants to introduce is a variable intervals that don't go beyond 2 years. So if there's no significant change within 2 years, you kind of pretty much could stop that ultrasound surveillance. Also, in the new guidelines for the 2025 thyroid nodule management, we have a range for doing the biopsies. So we will going to be more inclined, or the American Thyroid Association recommend to do FNA in smaller nodules if it's risk factors for thyroid cancer, and will be recommended doing an FNA thyroid biopsy in a larger nodule or with a larger size if the patient is elderly or have comorbidities. So low suspicions, you see they give us that range of 1.5 to 2.5. We follow up 12 to 24 months. Intermediate suspicious, the ETA is now suggesting doing between 1 and 2. You will do for a 1 centimeter nodule if your patient has risk factors or is a young patient, and the follow-up interval is between 9 to 18 months. If I high suspicious, they want the follow-up between 6 and 9 months. So the new guidelines, I think, are including more the clinical decision, and it's interesting to see what is going to be the result in terms of the issue with unnecessary FNA thyroid biopsies. Um, in my experience, the TIRAS bring the advantage. They are easy to be followed by our radiology colleagues and also our surgeons colleagues, and allows multiple specialties to be unified and standardized on the thyroid nodule evaluation. Here in J. Haley VA, we followed the 2017 TIRAS, and we have noticed that allows us to be more objective as an scoring system when we do an evaluation of a thyroid nodule. Okay, so your patient goes to thyroid FNA. So the results of the thyroid cytopathology is going to be reported based on the Bethesda system. It's basically 6 categories. Number 1, non-diagnostic, basically meaning was not enough cells collected. That requires a repeated FNA. Number 2, benign, that could have a risk of malignancy up to 3% and therefore requires follow-up. Number 3, atypia of undetermined significance. So the category 3 and 4 is what we call indeterminate. That basically means the cells are are actually abnormal, but not consistent with malignancy. So that group, the category 3 and 4, indeterminate cytologies will require further analysis with molecular thyroid testing. The category 5 is suspicious for malignancy, then surgery is indicated, and malignant also will indicate surgery. Lobectomy, based on the American Thyroid Association guidelines, could be considered in patients with thyroid nodules proven to be malignant less than 2 centimeters without concern for neck lymphadenopathy. So if a patient has an indeterminate cytology, Bethesda 3 or Bethesda 4, we could order one of those commercial thyroid mutations panels. They are run in the same FNA sample. I want to point out here that the thyroid sequence and the ThinGen X, so the first one in the first row and row number 3, are the ones that has the higher positive predictive value and negative predictive values. So having a negative predictive value of 97% for thyroid sequence and 92 to 94% for thyrogen X will give you reassurance if you have indeterminate cytology and the molecular markers is reported negative. That patient will be appropriate for observation, and you will not need to send that patient for a lobectomy or thyroidectomy. So that's the value of doing the mutation panel analysis. So what the mutation panel analysis is looking for is for those genetic markers associated with thyroid cancer. So we have a low risk group, RAS-like, that's usually present in follicular variant of thyroid cancer, usually non-aggressive. The BRAF-like intermediate risk, and those patients will require at least a lobectomy or total thyroidectomy. And then we have the high-risk mutations that could be seen in anaplastic thyroid cancer, one of the most aggressive type of thyroid cancer. So that's the genetics that we look when we do the thyroid molecular panel in an indeterminate thyroid nodule biopsy, Bethesda 3 or Bethesda 4. To summarize, if we have a nodule that have a benign cytology, we do in general a follow-up ultrasound in a year. If it's no change, you can consider extended that observation for a total of 5 years following the surveillance guidelines for the TIRAS. Again, we will wait for the new 2025 ATA guidelines to decide what will be that appropriate length. But I think a benign nodule that has unchanged ultrasound in a year could be followed up to 2 years or up to 5 years. On the other hand, if say any intermediate nodule or high risk suspicious nodule, you definitely wanted to follow yearly, maybe for 5 years to see if any changes. For those nodules that didn't have a biopsy at all, didn't meet criteria for biopsy, we had different options there on that table. And now, referring to the right side of the table where they mention high suspicious nodule, you maybe will do the ultrasound just between 6 or 12 months. If it's intermediate risk, you do it between 12 months and 2 years. Very low suspicious, you will do that follow up within 2 years. Basic principle is if a nodule shows more than 50% increase in volume, will be indicated to repeat a FNA. Or if it's any new suspicious features like changes in shape or presence of calcification, those will be also an indication for repeating an FNA. If a nodule is stable again after 2 years follow-up or max of 5 years, surveillance could be stopped. Okay, so with this, I conclude my presentation. I now am open to any questions, and please email me if you have any questions about what we have discussed today. I know it was a lot of information to go through, but this is kind of an extensive topic. And well, I'm here to answer any possible questions that you could have.
Carlos, that was a great talk. Always, this is John Turtolo. A great talk. I wanted to, excellent, everything I went through, and it made perfect sense. And I think the guidelines have been very helpful over the years, and they've gotten much easier to make decisions. One thing I wanted to add, and I'm sure you're aware of this, sometimes medullary cancers show up on ultrasound with some features that are unlike other, follicular and papillary cancers. And sometimes you have a suspicion, even though the person does not have a family history. So I would encourage occasionally when that happens to go ahead and get a calcitonin level. Also, if a person can't get molecular testing and they come up with an indeterminate category 3 or 4, I think that's another good reason to get a medullary level. And I know we added that on at Moffitt when I was over there. I don't know if they still do that or not, but I think it's very helpful. If you catch a medullary before surgery, it's very helpful, I think, this is for your staging of your surgery. So I just wanted to add that, but once again, Carlos, excellent talk, and I appreciate it.
Thank you, Dr. Torolov. And I definitely agree. If you are dealing with a highly suspicious nodule, I think in that scenario will have a value, and adding a calcitonin level. In Europe, when you have an indeterminate level of calcitonin, which is very frequent, a level which is between 10 and less than 100, they usually do a calcitonin stimulation test. But we don't have the substances used for that kind of a stimulation available here in the United States. So it leaves us in that kind of gray zone. But with a highly suspicious nodule, I think make a lot of sense doing that screening also with the calcitonin. Thank you.
Appreciate any other questions. I agree. Excellent talk, Carlos.
Hi, Dr. Palacio. This is Rosa. For those who doesn't know me, I'm one of the endocrinology fellows. Dr. T, I'm actually rotating at Moffitt, and they still do add the calcitonin level with intermediate nodes. It's part of the pathway. Dr. Palacio, my question was more regarding those nodules that don't meet criteria for FNA, and what does the guidelines say? Like, you keep monitoring them every 6 to 12 to 2 years, depending on how suspicious or not they look. But does the guidelines say any specific, like, when to stop the surveillance of those nodules that never met the criteria for FNAs?
That's a very good question. I think we'll have to wait for the actual new document to be published, and hopefully before the end of the year from the American Thyroid Association. But what has been presented in 2023 or 2024 ATA annual meetings is that a big component of that decision will be what are the risk factors for the patient. And higher the risk factors will be the tendency to prolong that surveillance, and lower the risk for the patient also is going to be the tendency to just complete it a 2 years period if it's no significant change.
Excellent. I think that's our first trainee question of the entire Grand Rounds academic year. We love it. Thank you, Rosa. We need more fellows and residents to ask questions. Excellent question. And you are the first of the year. So fellows and residents, do not be shy. All right, Jen, anything in the chat?
No, we're okay on the chat.
Okay, with that, we're right at 1 o'clock. So I'm going to thank Dr. Palacio for, again, a wonderful talk. We have really been blessed by some outstanding Grand Rounds to begin our second half of the year. Next week, another outstanding talk with Dr. Porterfield from infectious diseases, talking in the realm of HIV disease. So look forward to that talk next week. And that'll be followed by an outside speaker with an option to attend at B107 We really going to want a lot of house staff to attend in person. So I'll be working with Dr. Aller for that one. Actually, I think that's the week after. So I'm getting
we've got Dr. Jackson next week.
That's right, Dr. Jackson next week. I jumped. So thank you, Jen. So to reset, Dr. Jackson, who's our new head of student affairs, associate dean for student affairs, Dr. Christopher Jackson will be giving the talk next week. Thank you, Jen. Right now, Dr. Porterfield was having a VTAC probably when he was hearing he got moved up a week by my scheduling. But no, Dr. Porterfield, if you're on, you'll be February 20th. Next week, Dr. Jackson, our new Associate Dean for Student Affairs, will be giving an excellent talk on scholarship for the busy clinician. I'm really looking forward to that talk. How do you keep that spirit of continued learning, adult continued learning, if you will, in such busy clinical time? So that's going to be fantastic. That's next week by virtual teams, then followed by Dr. Porterfield, February 20th, then followed by an outside speaker from UAB for palliative care. So we've got a great rest of February lined up. Thank you again to Dr. Palacio, and as always to Jen Newcomb, our administrator. Have a great day, everyone.
Thank you for the invitation. Bye-bye.